working in Saudi Arabia. We have worked together on many occasions when I used to conduct programs for Elevate TV. He used to be my guest on a regular basis. He's a very highly qualified physician, internist, and nephrologist, multi-faculty, multi-specialty, and he's also a specialist in ECMO, which some of you may be familiar with. He has several qualifications and many attributes. He did his graduation from India, and after doing his MBBS, he traveled to UK and was trained in the top university hospitals in London, like Guy's and St Thomas's and Barts. And then he started working in various centers as an internist or interventionist, and then nephrologist. Is multi-faculty. So he's got the advantage and the experience to talk about various conditions. Now, we've chosen this topic of acute kidney injury and the fluid balance that we will discuss with you, as it is growing in importance every day as we move forward, because kidney injury is a major problem. And the definition, the terminology, etc., that Jadullah is going to tell us would be amazing. So welcome, Jadullah, over to you.
Thank you for your kind words, Professor Shabi. Let me just share the slides.
I should also mention that Jadullah is honorary professor in Sadiq International University.
Glasgow. ايه جلاسكو مشتغل بجلاسكو بلندن مشتغل.
I am not able to change the slides from my end.
You can do that. If you ask him to change, he'll change it.
Next slide, please. Thank you very much. So today I'm going to talk about fluid management in acute kidney injury. I'm going to give an introduction. I'm going to talk about historical perspective of how fluids have been given, what fluids have been given first. And then I'm going to touch on the AKI definition, the current definition, and the challenges with the definition, and what the future definition that has been proposed. Then I'm going to talk about various types of fluids, and I'm going to talk about the 4D approach to giving fluids, and I'm going to talk about the ROSE approach to giving fluids and resuscitation, and briefly touch on fluids in hepatorenal syndromes and contrast-induced nephropathy and oncology patients, and then take your questions. Next slide, please. Next. So as we know that from ancient times, water has been given a high importance, i.e. fluids. And in Islamic context, water at times has been referred to as a Khaliq, the creator, as the sustainer, provision, which it has been, most of the people take in terms of rain, but in terms of medical perspective, the composition of human body, a major component is fluid, and it's a giver of a life, and as a teacher, as an accountant. So if you end up having a fluid overload, you end up having issues from the medical perspective. And Shakir, and for purification, where you see that lots of toxic stuff is being washed out by water via the route of urine, i.e. kidneys. Next slide, please. So most of the fluid is situated in the intracellular compartment and the interstitial fluid. A small amount is situated in the plasma and other fluid spaces. Next slide, please. So if you look at majority of the organs, brain, lung, liver, kidneys, heart, they have got about 70 to 85% of its composition is made up of fluids, i.e. water, including the muscles as well. So in a 70 kg man, you have got 42 liters of fluid. So 42 liters is a major component. So if you split it down, that's about say 55% of is in intracellular fluid and 45 is in extracellular fluid. Among that 45% of extracellular fluid, majority is in the interstitial compartment. It's very important to know this because when we give fluids, blood products into the veins or into the blood circulation, majority is in a compartment that doesn't compose the major composition of fluid in the body. Next slide, please. Now, if you look at it, the composition in terms of electrolytes varies depending on where you are looking at. If you look at the ileal fluid and colonic fluid, they have got a high sodium content. It's almost same as the plasma, and a chloride content similar to plasma content and has got some bicarbonate. Whereas if you look at the pancreatic juice, is extremely high in bicarbonate content, whereas gastric juice contains none. The reason for this is when you are considering replacing fluids, and you have to think about where the fluid is going from. Sometimes if you have got ileal or colonic or gastric losses, as in patients with vomitings and diarrhea, that this basic knowledge helps in replenishing with appropriate and adequate amount of fluids. Now, looking at the compartments, if you look in the red is the plasma, i.e. looking at the blood compartment, the blue is the interstitium and the yellow is the intracellular fluid. The composition in terms of intracellular and interstitial fluid doesn't vary much, but there is a huge and a significant difference in the composition of electrolytes in the intracellular compartment and the extracellular compartment. Next slide, please. So at the end, this is a cross-section of a capillary. At the arterial end, there is a hydrostatic pressure is higher compared to colloid osmotic pressure. So that leads to filtration of fluids at that point, and the mid-capillary level, this is 0, whereas at the venous end of the capillaries, there is resorption of fluid back into the capillary end of venous end of the capillary because the blood colloid osmotic pressure is higher than the hydrostatic pressure. Next slide, please. So the composition, you have seen in the previous slide that there is a huge difference between the intracellular electrolyte composition and the interstitial and extracellular electrolyte composition. This is kept in check with various pumps and various mechanisms that are in the cell, on the surface of the cell. Next slide, please. So if you look at the composition of various intracellular fluids, on the right-hand side, you have got composition in the various compartments, i.e. inside the cell, interstitium, and in the plasma. Whereas on the left-hand side, you have got various fluids that are commercially available. So let's have a look at normal saline. The normal saline, that is 0.9% sodium chloride, has got a sodium content of 154. Now, the serum sodium content is a normal range is 135 to 145. So you're giving much more sodium when we are giving normal saline, and we are giving chloride in excess as well. So you have to bear that in mind. So chloride composition is 154 in this, and serum chloride is not that way high up. It's about less than 110. So you're giving quite a lot of chloride and quite a lot of sodium compared to what the plasma and serum sodium and chloride composition is. Whereas there is no potassium in this, there's no calcium in this. Where if you look at the Ringer lactate solution or Hartmann solution or plasmalite concentration, so Ringer lactate has got a sodium composition of content of about 130 and chloride of 109. It does have potassium 4 and calcium of 3. So what it means to say is much more closer in terms of sodium composition and chloride composition to plasma and serum, whereas saline has got a lot of sodium and a lot of chloride, which brings its own problems if you are not replacing losses which are from the lower GIT. And if you look at the other saline, they are not used at resuscitation fluid 3%, 2%, and 5% and 7.5%. They are used in special circumstances to raise the saline, like in cerebral salt wasting, or when you have got increased intracranial pressure and you need to decrease the cerebral edema. So we do not use 5% dextrose as a replacement or resuscitation fluid. Next slide, please. So when did we actually start thinking about giving fluids into the body? This is a very long story going back to 1667. Jean-Baptiste Denis was a physician to Louis XIV. So he first gave blood from animal to animal, that's sheep to sheep. And after doing that in 3 sheep, they survived. I don't know how much blood he gave into the sheep. The next experimentation he did was he gave blood to humans the blood was given from a sheep to a human. So they got a hold of a gentleman, and he was transfused blood products.
Hello, have we lost you?
Sorry, there was a loss of voice. Sorry.
Yes.
The transfusion, so they started giving transfusion from animal into, so they transfused from animals to human. So the first human received 12 ounces of sheep blood. Interestingly, he survived. The reason why he had become unwell was he had fever for 2 months and he had leech therapy and lost a lot of blood. I'm not sure how much of blood went into the body, but the patient survived. So this was the first documented incidence of ever giving anything into a human being from animal. Later on, similar studies were conducted by Richard Lower with successful results. But subsequently, Jean-Baptiste transfused into a human, and at the beginning of 3rd transfusion, he died. He seized and died in front of a lot of people. So he was sued. He was taken to the court. It was found that the first transfusion went well, and subsequent to that, there was a lot of animosity among the community. So they poisoned the patient with arsenic, and he ended up having seizures because of that. But the court that heard said we should stop these practice of blood transfusion and felt it was unsafe. So the transfusion practice was stopped at that time. Next slide, please. So in the interim, people had tried other fluids in terms, whether you see, one of the things that was tried was giving milk, human milk and animal milk, without any successful results. Then subsequently, James Blundell got the practice back of blood transfusion into practice, whether this would improve with not much success. That's the apparatus that he used. Next, please. And he's published his studies of his transfusion practice, and you saw the gravitator. Next, please. Next, please. So at the time of cholera, Shogansi did animal studies where he studied the composition of blood in animals who had cholera, and found that they were depleted in water and salt, and he published his results. And subsequent to that, Dr. Latta devised a solution which is now called as a saline solution, normal saline solution, and transfused patients who were having 2nd stage and advanced stage of cholera with normal saline with successful results. And he published his results in Lancet, stating significant improvement. Next slide, please. But Leith and his colleagues subsequently wrote articles stating that though the results of saline transfusion in cholera was beneficial, but the effect was short-lasting and was not long-lasting, and suggested that there could be harm from transfusing this in excess amounts. Next slide, please. People have tried to give fluids through other source routes, i.e. Parectally in patients with peritonitis, not with much success. Next slide, please. Then came the next fluid on the block, that is the Ringer lactate, manufactured by Sydney Ringer. It had better results, but again, not much in common use. Next slide, please. The first human-to-human transfusion was done by a surgeon called George Washington, who is the person behind the Cleveland Clinic at its inception. And it was done successfully between brothers without any harmful effects. Next slide, please. Albumin, the use of albumin came very late in the 19th century rather than the earlier fluids. Next slide, please. Next slide, please. Now, coming to the definition of acute kidney injury. Acute kidney injury at the current time is described as a rise in the creatinine 1.5 to 1.9 times the baseline, or greater than 0.3 milligrams per deciliter or 26.5 micromoles within 48 hours time, but less than 7 days time. There is another criteria to measure it, the urine output criteria, where the urine output is less than 0.5 ml per kg per hour for 6 to 12 hours. And it's divided into various stages, stage 1, 2, and 3. Stage 3 is anybody who is having a rise in the creatinine 3 times the baseline or greater than 354.6 micromoles, or who has been started on a renal replacement therapy. The current definition does not take into context or consideration the subclinical AKI or the pre-AKI stage and or the biomarkers. Next slide, please. Acute kidney injury is associated with increased cardiovascular mortality and morbidity. AKI is defined if somebody has got renal dysfunction that's less than a week. But if it's more than a week but less than 3 months, you classify it as acute kidney disease. And if the renal dysfunction persists beyond 3 months, you classify it as chronic kidney disease. When people are classified as acute kidney injury, the structural criteria in terms of acute kidney injury, they could be proteinuria or hematuria, but it's more marked in acute kidney disease and chronic kidney disease. Next slide, please. The various risk assessment tools that have come into practice, one is the renal angina index, the modified renal angina index, and renal function reserve assessment, and new biomarkers. Next slide, please. So there are different biomarkers that are being tried, and a lot of large studies that have been done looking at various biomarkers and a combination of biomarkers. They are secreted by different places in the tubule, where there is ascending limb or the descending limb or proximal tubule or distal tubule, and at the glomerular site. The site from where these markers are produced will help us in finding out where the injury is happening and then subsequently prognosticating the injury. Next slide, please. So the role of novel biomarkers would be in the diagnosis, i.e. the early detection of injury and location of injury and etiology. Thereby, we can determine our therapy precisely It also may help us in early prognosis by telling us about the extent of injury, whether the injury is ongoing or there is initiation of recovery to the insult or the risk is worsening. And in the later course, it will help us by telling us what is the risk of future CKD and end-stage renal disease in that particular subset and that particular patient per se, and the risk of mortality and what's happening to the renal reserve. And the AKI may follow on to full recovery or may end up having AKD and then subsequent CKD, or in severe cases, end-stage renal failure being dialysis dependent. Next, please. Next. Next slide, please. So this is an histological diagram. It demonstrates what happens to the nephron if you have a mild AKI, moderate AKI, and severe AKI, as you can see on the images in the center and on the right. If the AKI is mild, the glomeruli and the renal function may recover, but the long-term outcome or sequelae of having even a mild AKI that is, it increases the risk of cardiovascular events in future. People who have had AKI will have a lesser renal reserve. The nephron may not go back to normal state, and there may be loss of function of the nephron, either partially or completely, thereby decreasing the renal reserve by decreasing the number of nephrons. The severe the insult, the more the nephrons are lost. Though the creatinine may go back to baseline, but the risk in terms of progressing to CKD and cardiovascular disease and a possible kidney cancer increases with the severity of the injury. Next, please. Next, please. Next slide, please. So modified renal angina index. So there are various parameters that are taken into account where the patient is admitted to intensive care and if they have got a solid or stem cell transplantation. If the patient is on organ support, i.e. mechanical ventilation or inotropic support or both, they score higher, and anybody scores greater than 8 have got a significant risk of progressing on to having an acute kidney injury. Next, please. So, as depending on the severity of the insult, the renal functional reserve will go down. And there are studies that have demonstrated that renal functional reserve decreases with a significant AKI. Next, please. Next slide, please. This is the proposed new definition of AKI, in which 1S is the new stage that they're planning to add, where there is no change in serum creatinine and no decrease in urine output. Currently, we classify or define AKI by a rise in serum creatinine or a decrease in urine output. In these cases, you're trying to catch at-risk patients and subclinical AKI patients. And in these, only the biomarkers are raised and the rest is okay. And they have they're going to subclassify stage 1, 2, and 3 as A and B, B standing for biomarker positive and A standing for biomarker negative. The intention of this classification is to catch the acute kidney injury in very early stages or subclinical stages, so that corrective measures and preventive measures can be initiated at a very early stage, thereby preventing the renal insult and damage, thereby preventing and decreasing the cardiovascular morbidity and mortality it brings, and also preventing the incidence of end-stage renal failure and renal impairment. Next, please. So as you can see, the earlier you act, the better it is, thereby preventing the sequelae of acute kidney disease, acute kidney injury, and acute kidney disease. Not only it leads to chronic kidney disease and end-stage renal failure at its worst paradigm, and cerebrovascular and cardiovascular accidents, incidents, but also the baseline blood pressure goes up, the risk of infection and sepsis is higher in patients who have got AKI, AKD, and CKD. The risk of malignancy is higher, the risk of GI bleed is higher because of platelet dysfunction, and the risk of osteoporosis and fractures is higher. Next, please. So it's the baseline kidney function and the early action that is very important. As you can see, the increased risk phase, there are biomarkers that can go up, as well as during the kidney injury phase, that the biomarkers that go up, and that's the time you need to act. Next slide, please. Next slide, please. So what does the KDIGO guidelines suggest or tell us about managing acute kidney injury? What it tells us is to discontinue all nephrotoxic agents whenever possible. Ensure the volume status. By that, it means that make the patient euvolemic and make sure the perfusion pressure is good. Basically, what they're telling is the renal perfusion pressure. Renal perfusion pressure is nothing but mean arterial pressure minus intra-abdominal pressure. So you should maintain it greater than 60. Consider functional hemodynamic monitoring where appropriate, i.e. it could be invasive or non-invasive. We need to put in the central line into the patient and arterial line into patient, and they may be attached to hemodynamic monitors, i.e. either a LITCO or a PICO or a Vigilio. There are non-invasive monitors that have come into the market which doesn't need the central line and arterial line, wherein a probe can be attached like this SpO2 SATS probe that gives the parameters. The norm, depending on what hemodynamic monitoring you're using, the indices that you get are variable. Like for example, with LITCO, you can get cardiac output, cardiac index, stroke volume variation, and systemic vascular resistance index. And if you're using PICO, you will get extravascular lung water index and pulmonary capillary index as well with that, and global end diastolic volume index. So that will help us in fluid resuscitation. Bedside ultrasound is of immense use, where you can look at the inferior vena cava and the superior vena cava. Looking at inferior vena cava collapsibility and distensibility index. Normally with the respiration, if there is greater than 50% collapsibility, it indicates fluid depletion. It is not the all and all, because if patients have got tricuspid regurgitation or right-sided raised pressures, then the inferior vena cava can be distended even when the patient is fluid depleted. Apart from that, you can do a paired arterial and venous carbon dioxide difference. 0.6 and greater than 0.6 suggests intravascular fluid depletion. You can check the superior vena cava oxygen saturation. Less than 70 can indirectly suggest to us that there is in fluid depletion. Apart from that, the other parameters that can be used is straight leg raising. Apart from that, you can use pulse pressure variation and expiratory occlusion. I'll talk about this in detail in future slides. You can monitor serum creatinine and urine output, make the patient euglycemic, avoid radio contrasts wherever you can, and consider working up for the etiological cause with non-invasive tests, and make sure you're dosing antibiotics appropriately, because with changing renal function, certain antibiotics, if they are giving in higher concentrations, can be nephrotoxic. Avoid nephrotoxic antibiotics, especially with MDR bugs. Using antibiotics like colistin and aminoglycoside can lead to nephrotoxicity. And avoid subclavian catheters, because that can give rise to stenosis and future access problems. Next slide, please. There are lots of causes of AKI, but the predominant and overriding cause is sepsis, followed by cardiorenal syndromes and drugs and contrast. Next slide, please. So what do the KDIGO tell us about management of AKI with fluids? They suggest, in the absence of hemorrhagic shock, we give isotonic crystalloids rather than colloids. They don't further go on to say which crystalloid to give, and if at all, to give colloid, to which subset to give colloids to. The best resuscitating fluid in hemorrhagic shock, without saying, is blood and blood products. Next slide, please. It is very important to use the right type of crystalloid fluid, and it is important to achieve a euvolemic state, okay, and to keep the patient in a normotensive status for that particular patient. So a MAP of 65 would be adequate for a patient who is 70 kgs, and a non-hypertensive but you may need to run higher MAPs for patients who are hypertensive. There have been studies that have been done where they have compared 65 to 70 to MAPs of 80, and they have found no significant difference. But in hypertensive patients, you may need to run slightly higher MAPs compared to the normotensive patients. Next slide, please. So if you look at the macrocirculation, it's very important to maintain the renal perfusion pressure. That is done, one, by making the patient euvolemic. Once you have made the patient euvolemic, there's no point in giving excess fluids, because that will lead to renal edema and will worsen AKI, will impair the recovery of renal function. If the blood pressure is still low after giving adequate fluids and you have fluid replace the patient, then inotropic support should be considered where appropriate, and aim for a renal perfusion pressure of greater than 60. Next slide, please. Next slide, please. Certain drugs can cause AKI. Certain drugs can cause rise in creatinine without actually causing an injury. The simple example is trimethoprim and H2 blockers like ranitidine and cimetidine. They prevent the secretion of creatinine at the tubular level, thereby increasing the creatinine in the blood. So there is no acute kidney injury there, but the creatinine has gone up. So this is one of the fallacies of the classification or the current classification system. Whereas the drugs can also cause injury by directly damaging the various places of tubules, and that can be in isolation or in combination with dysfunction. Next slide, please. So what does the NICE say about fluid resuscitation? What it tells you in summary, it doesn't give you much details, though this slide is very elaborate. What it tells you is to follow a simple ABCDE approach, do a good examination, looking at the fluid status, making sure whether it's a warm shock or a cold shock, getting good IV access, and where you feel that the patient is intravascularly depleted, then give a bolus as an initial resuscitative therapy of 500 ml of crystalloid, and reassess the response. And if the patient is responding, keep on giving fluids until the patient stops responding to the boluses. And then subsequently, once you have done the initial bit, then comes the maintenance phase, where you give the maintenance fluid depending upon how the electrolyte levels are and what the fluid needs of the patient is, and replace electrolytes along with the fluids, and then look at the overall status of the patient and continue resuscitation. Next slide, please. So there has been a new concept in terms of fluid management, like there is an antibiotic stewardship in septic shock. There is also a fluid management stewardship, not only in septic shock, but also in AKI patients. It is important to consider the 4 Ds on 4 phases of fluid therapy. So we are going to talk about 4 Ds and the ROSE concept of fluid resuscitation. Next slide, please. So what are the 4 Ds of fluid therapy? One is the drug, means what type of fluid we are going to give, whether you're going to give saline fluid or we're going to give balanced crystalloid. When we talk about saline, we are talking about normal saline, but the other groups in the saline are 0.45%, 2%, 3%, 5%, 7%. And when we're talking about balanced crystalloid, we're talking about Hartmann's, ringer lactate, plasmolyte. Duration, how long are we going to give? Dosing, how much are we going to give? And when are we going to start actually removing the fluid, stop giving the fluids and actually removing the fluid from the body? Next slide, please. So I'm going to talk at length about drug dosing duration and de-escalation in the coming future slides, please. Next slide, please. Now, drug. Is it we're going to give crystalloid, colloid, synthetic versus blood-derived, balanced versus unbalanced? Are we going to give IV or oral? And what osmolality we are going to give? And what electrolyte composition we're going to give? And what this will also depend on other comorbidities the patient will have. The type of fluid that we give will be different if a patient has got an end-stage renal failure and a liver failure compared to people who do not have renal dysfunction and liver dysfunction. Next slide, please. And what is the reason for giving the fluid? Are we resuscitating the patient? Are we in a maintenance phase? Are we in a replacement phase? Are we giving it as a nutrition? Or is it in the form of a nutrition or combination of these? Next slide, please. So resuscitation phase. Let's talk about the resuscitation phase and what fluids we are going to give. So the Surviving Sepsis campaign suggests that we give 30 ml per kg of fluids within the first 3 hours as a loading dose or a bolus dose. So when you give a fluid bolus or a fluid challenge, you normally give about 4 ml per kg as a fluid challenge. Now this varies. You may give lesser amounts of fluid and in small boluses, sometimes in many boluses of 100 ml of saline instead of 250 ml or instead of 500 ml in patients who have got heart failure. And you may give lesser amount of fluids in patients who have got end-stage renal failure and who are on dialysis, either hemodialysis or peritoneal dialysis. In heart failure patients, one of the easy things to do is to do a straight leg raising test, where you make the patient lie down, if they can lie down, and raise the legs for about 5 minutes. And the blood pressure, mean arterial pressure, is checked pre and post straight leg raise. And if there is an improvement in the mean arterial pressure, then it suggests that the patient is fluid depleted and you can safely go ahead and give fluid, and there is no worsening of shortness of breath. So this is a bedside thing that you can do normally and safely in these patients. Next slide, please. So in the resuscitation phase, you're going to give more fluids, and the fluids are going to be kept on giving in a bolus fashion. I'll talk in more length in the coming slides what hemodynamic monitoring parameters that you're going to use and what strategies you're going to use, both in ward settings and in ICU setting. So in terms of drugs, please make sure that you do not use normal saline inappropriately. It carries the risk of causing hypochloremic metabolic acidosis. I'd be very cautious of using ringer lactate in patients who have raised potassium, who are completely anuric, and dialysis patients. So I would use saline in those patients as an initial resuscitative fluid. There is no role of gelfusion or in such patients, and albumin in the early patients in majority of the patients, except for a special subset of population. Make sure that in the initial phase, you would need to give a lot of fluids, so you may need to run the fluid balances positive. And as you go on to resuscitating the patient in subsequent phases, you may go from positive to neutral, and then neutral to neutral, and then to negative in the subsequent phases, the phases of fluid resuscitation. Next slide, please. So which fluids are we going to use, and what sort of saline or balanced crystalloid we're going to use? And have we got any studies that can help us in resuscitating these patients? Now, this is a New England Journal of Medicine study by Wesley Group, where they looked into balanced crystalloid versus saline. And it showed no difference in hospital-free days between these two groups. This was the SALT study. Next slide, please. So this is another study that looked into chloride restrictive versus liberal. In this, they clubbed chloride group as people who are receiving 0.9% saline 4% succinate gelatin solution and 4% albumin solution, and the balanced crystalloid as plasma light and Hartmann solution. And they found that people who had balanced solution had lesser incidence of AKI and use of renal replacement therapy. So it was 14 versus 8.4% in AKI, and renal replacement therapy was 10 versus 6.3%. Next slide, please. So this is the SMART group. They looked into crystalloids, saline versus a balanced crystalloid. And they found that administering a balanced crystalloid, there was a slightly decreased in hospital mortality and new renal replacement therapy, and persistent renal dysfunction was lesser in patients with balanced crystalloid. Next slide, please. Now, this is a study from Brazil, BASICS randomized controlled trial. They did not find any significant difference between these two groups. Next slide, please. This is another study that was published in NEJM from the New Zealand and Australian group, PLUS study. And plus, this also did not show any significant difference in terms of AKI or mortality and renal replacement in between groups that receive balanced crystalloid versus saline. Next slide, please. This is the split trial. It has the similar results as the PLUS trial, and it also did not show much difference. Most of the patients in this trial were admitted in cardiothoracic and vascular ICU. It's about 11 cardiothoracic and vascular ICUs and 3 in medical and general ICU. They also did not see any difference in these two groups, i.e. the group that received saline versus balanced crystalloid, in terms of having a progression towards AKI and needing of renal replacement therapy or mortality. Next, please. So in the maintenance phase, the fluid depends upon what the requirements are. So if you're not giving any replacements in terms of losses, either through colon or vomiting in terms of gastric or any drains and fistulas that could be in particular abdominal areas, then the normal requirements would be 25 to 30 ml per kg of body weight water, and potassium of 1 millimole per kg and sodium 1 to 1.5 millimole per kg. There should be some form of dextrose, either through enteral nutrition, parenteral nutrition, or in 5% or 10% dextrose to prevent starvation ketosis. Next slide, please. So when you are resuscitating a patient with acute kidney injury, it's of paramount importance to make sure that you are not over-resuscitating the patient, as it can increase the venous pressure, and that subsequently leads to decrease in renal blood flow, and by reducing the transrenal pressure gradient, that is in turn brought about by raised interstitial pressure and renal edema. And when that happens, there is an increased renal vascular resistance and reduced ultrafiltration, and the tubular pressures are raised as well. Giving a lot of fluid causes ascites and third spacing, and that causes increase in intra-abdominal pressure, and that can lead to intra-abdominal hypertension. That can in turn lead to a decrease in the renal perfusion pressure. By decreasing the renal perfusion pressure, next slide, please. When you're doing the replacement fluids, it depends on where you're losing the fluids from. For example, if it's from stomas, drains, and fistula that are in colon, and that you have got a high loss of sodium and chloride, normal saline may be a better replacement fluid. For patients who are hyperthermic, again, normal, depending on what the losses are, the ideal fluid will be chosen. Patients who are polyuric may lose significant amount of electrolytes as well, i.e. potassium, calcium, magnesium. Especially patients who are recovering from a tubular injury, they are polyuric and pass a lot of urine and lose lots of electrolytes because the tubules are not functioning properly. then ringer lactate may be a better fluid option instead of normal saline. People who lose a lot of sodium and chloride in the urine, particularly in cerebral salt wasting and salt wasting nephropathy, may need either normal saline or hypertonic saline, depending on what the symptomatology and losses are. So if their sodium content is very low because of this, then they may need, and if they're associated with cerebral dysfunction or decrease in GCS or seizures, they may need hypertonic saline temporarily to raise the sodium by 2 to 4 millimoles or until the symptomatology resolves, and then resuscitating with normal saline subsequently. People with diabetes insipidus may need giving desmopressin instead of giving fluids so as to prevent the losses. Next slide, please. Next slide, please. Sorry. So nutrition can be parenteral or enteral, and it's an important component. And you do replace fluids by feeding through nasogastric tube or orally. It should have appropriate amount of calorie and protein load. It's a completely different discussion, so I wouldn't go into details of that. And it should be started as early as possible. In the first 24 hours, normally you do not initiate nutrition, but once the acute phase is over, early initiation of nutrition is recommended. And whenever you can, and whenever the patient gets better, you should de-escalate it by resuming the oral feed when appropriate. Next slide, please. Next slide, please. Next. So the slide represents various fluids that we give, and there is an association of harm with the gelatin and hydroxyethyl starch. So they have gone out of fashion and vogue, and hardly anybody uses gelifusin or has solutions nowadays. Most people use isotonic saline and balanced crystalloid, and in certain circumstances, 5% or 20% albumin. Next slide, please. So duration, you have to give the fluids for the duration that is needed, and it has to be goal directed, and it has to be directed by looking at the clinical parameters, clinical assessment of the patient, whether the patient is intravascularly depleted, and does the patient need an ongoing maintenance or resuscitative therapy. And you should stop the fluids when you no longer need it. Next slide, please. Having a positive fluid balance is associated with a negative outcome. Malis and myself, when I was doing the training days, we did a study looking at the oxygen delivery index and AKI, and we found that people who had a low oxygen delivery index had a higher incidence of acute kidney injury. And we also found that people who had a positive cumulative fluid balance had a lesser renal recovery and a higher incidence of acute kidney injury. And further studies were done, and this has shown that people who have got an overall higher cumulative fluid balance have got a higher adverse events, including acute kidney injury. Next slide, please. So this is another study that was published in the New England Journal about restrictive IV fluid therapy. Next slide, please. Next slide, please. So in this, in the previous slide, there was not much difference in terms of outcome, whether you use restrictive fluid therapy or the liberal fluid therapy in terms of mortality at 90 days. But there have been a lot of studies that have shown that a cumulative fluid, positive fluid balance is associated with poor outcomes. And recently there have been published trials and data in patients with pancreatitis. Over-resuscitation is associated with poorer outcomes, and they should be appropriately resuscitated. So we have talked about the 4Ds, drug, duration, dose, and now comes the part which is the Rose concept of fluid therapy. So when you have got a septic shock or a hit and the patient is hypotensive, you have got there are 4 hits that can happen. And I'll talk individually about them as we go along. Next slide, please. When we're talking about the dosages, one thing is very important. There's a saying, all things are poison, nothing is without poison. The dosage alone makes it so. The thing is not a poison, meaning to say that anything you give in excess can be poisonous. So it's very important when you are giving fluids not to give it in excess quantities. And it is very important also the type of fluid that you are giving in terms of replacement therapy, whether you are trying to replace something that is there in the extracellular compartment or intracellular compartment or interstitial compartment. Next slide, please. So this is a slide just to tell you how long does each individual fluid hang on into the system when it comes to 5% dextrose or ringer lactate or colloids like albumin. So if you see, the half-life of albumin is much more higher compared to balanced crystallite, and the worst is for somebody receiving 5% dextrose. Obviously, we don't use dextran anymore. Next, please. De-escalation. So when we have resuscitated the patient has got better and there is a lot of fluid has accumulated into the body and the patient's edematous. You need to remove the fluid that has accumulated in the body. And I'm going to talk about various parameters that we are going to see in order to remove the fluid, which is labeled nowadays as late goal-directed fluid removal. Next, please. So ROSE concept. So the first phase is the resuscitation phase. The second is the optimization phase. Third is the stabilization phase. And fourth is the evacuation phase. So what happens in the ROSE resuscitation phase? The patient has come very unwell into your ER or into straight from ER into ICU, very unwell patient who is very hypotensive, cold clammy, with capillary refill time that is markedly raised and dehydrated. From any point of view, you're looking at the whether the vitals or whether you're looking at the ultrasound or invasive monitoring parameters point of view. This is the very early phase of the shock. And this is the time there is a huge benefit if you give early adequate goal-directed fluid management, looking at the parameters, which I'm going to talk in the future slides, and administration of appropriate fluid. And you are going to end up giving a lot of fluid during this time. And the patient positive balance would read like, okay, he's received 1 liter, 2 liter, 3 liters fluid without having passed much in terms of urine output. But you need to aggressively resuscitate the patient at this point of time. A, to salvage the patient. B, to get the blood pressure up by optimizing the fluid depletion that this patient has got, so that vital organs are perfused adequately and doesn't get an ischemic hit to the liver, kidneys, brain, and other important organs. Insufficient resuscitation should be avoided during this phase. The second is the optimization phase, which is the second hit, which happens in hours times following the initial phase. Where you have started perfusing the organs and there is an ischemia reperfusion injury. Sorry, the slides have disappeared. So there is an ischemia reperfusion injury and the patient still is in a shock, but at this time, the blood circulation is flowing to the organs and lots of stuff that is being pro-inflammatory stuff that is being produced in the cells is being washed out back into the circulation, causing further vasodilatation. And at this point of time, it is important to give fluids again and to maintain a euvolemic status. So you may give fluid and they may sort of seep into the third spaces during this time. And this point, it is to salvage the organs. The first point was to rescue the patient, save the patient. If you don't resuscitate appropriately during a resuscitation phase, that it's likely that the patient may die because of shock leading to multi-organ failure subsequently. So it's very important, but at the same time, when you have got into optimization phase, don't be overzealous, because at this phase, if the patient still remains anuric, then you may throw the patient into pulmonary edema, or there may be excess third spacing giving rise to intra-abdominal hypertension. So during optimization stabilization phase, it is very important to look out for the signs that you're not causing pulmonary edema or third spacing the patient or causing intra-abdominal hypertension. And normally you can measure normally you can measure the intra-abdominal pressure by putting in a catheter, Foley's catheter. So in the stabilization phase, which happens in a days from the initial insult, i.e. patient coming with a shock, the ischemia reperfusion injury continues, but it's much more dampened down and the shock will get better. And here the focus should be on decreasing the amount of fluids that we are giving, and we should follow a conservative strategy rather than being overzealous in terms of giving fluids. And the emphasis would be whether you need to give maintenance or replacement fluids, or you should actually sit tight at not giving anything. So the overall fluid balance you are going to aim for during this time would be neutral to negative, and to support the organs so that they continue to be perfused, but at the same time not get fluid overloaded and edematous. And the last phase is the evacuation phase, when the sepsis has got better. Say it can happen in days and weeks, and then you need to provide a third hit, which is the global increased permeability index. Can you move to the next slide, please? Next slide, please. So in this phase, the capillaries may still be leaky and you may still have third spacing. But if the patient is not fluid responsive, please refrain from giving these fluids during this phase. Otherwise, you'll end up making the tissues edematous, and there will be an overall positive cumulative fluid balance and fluid overload. At the same time, this phase, late goal-directed therapy should be done, i.e. you may, as the stages progresses, you may need to remove the fluid from the patient by giving diuretics, either in the form of challenge or in a furosemide infusion. But at the same time, you should be aware that you should not diurese the patient, thereby causing intravascular depletion and causing a fourth hit of the shock and giving insult to the tissues, including the kidney, and further precipitating AKI. Next slide, please. So resuscitation phase, what are the target parameters that I can use? So I would use MAP. So as giving a bolus, as I suggested, you can give 4 ml per kg over 10 to 15 minutes. You can give small mini boluses of 100 ml. If you're worried, you can do SLR and give a bolus, either 100 or 50 ml, 4 ml per kg. That's the recommended bolus dose. And you can keep on repeating. Every time you give bolus, assess the response and keep on repeating until you don't get a response. And what do you mean by response? You're targeting a MAP of 65. Cardiac index, if you have attached the patient to invasive or a non-invasive hemodynamic monitoring system, of cardiac index of greater than 2.5, which is nothing cardiac output that has been corrected for that particular patient, depending on how body surface area, then pulse pressure variation, that's the variation that happens in the systolic and diastolic phase, of less than 12%, and left end diastolic area index, so LV end diastolic AI greater than 8 centimeters. Now, these cardiac index PPV, cardiac index SVRI and stroke volume variation will be displayed as numbers when you have got invasive hemodynamic monitoring done in the form of LITCO, PICO, Vigilio, Cheetah, or even if you have got a pulmonary arterial catheter institute. Next slide, please. So fluid bolus, we have talked about 4 ml per kg. What threshold? There should be 15% for fluid challenge. The response should be 15% for fluid challenge and 10% for passive leg raising test and 5% for end expiratory occlusion test to say that it is fluid responsive. Next slide, please. So what is the sensitivity of these tests, and what parameters are you going to use, and where you have to be cautious? So if you're using pulse pressure or stroke volume variation, you should have a improvement by 12% after giving fluid bolus of 4 ml per kg. Some people in certain organizations, the previous slide as you saw, it was 500 ml to a liter. So use higher doses in terms of bolus. So this cannot be done. Pulse pressure variation, stroke volume variation, IVC variation, SV, cannot be done in spontaneously breathing patients. So i.e. this is ruled out. You cannot do this in ward-based patient. This is for intubated, ventilated patients. So IVC collapsibility, at the bedside in a ward patient, 50% collapsibility indicates fluid depletion. SVC, not many clinicians use it. Passive raise, it is much more sensitive if the patient is attached to a cardiac output monitor. Nowadays, Baxter has come out with a cardiac output monitor, which uses a probe like a SATS probe and gives you the cardiac output. And if there's a 10% rise in the cardiac output, it is much more sensitive compared to just looking at the MAP, mean arterial pressure. Again, end expiratory occlusion test improvement by 5%. In an intubated patient, you can do it. And then suppose in a non-intubated, so you can ask them to hold for 15 seconds, but I don't think this is practical in all patients, especially patients who are acidotic or in shock, maybe tachypneic, so they may not be able to do that. Mini fluid challenge can be done with 100 ml, and you expect a 6% improvement rather than a 12% improvement if you're giving mini fluid challenge. And conventional fluid challenge, 4 ml per kg, some people say 500 ml. There are various studies that have been done. Some have been done with 4 ml, some have been done with 250 ml, some have been done with 500 ml. There is an improvement of 15% is what you would expect. Next, please. So what can you do at the bedside if you are there? Well, you can look in the ward-based scenario. You can look at, take an ultrasound. Ultrasounds are very widely available in lots of organizations. Look at the IVC collapsibility. If you are good at echo, nowadays there is a focus on teaching clinicians on echo. Most of the intensivists are trained in echo now, bedside echo. They look at the TAPC and MAPC, and diastolic and systolic volumes. They can look at apart from that, they can look at the lungs to see if there is any pulmonary edema and if there are any effusions. Whereas for bedside clinicians who do not have echoes, you can look at giving fluid bolus, looking at the parameters where there is improvement in mean arterial pressure. If you're giving minimum by 6, and if you're giving formals 4 ml per kg or 250 or 500 ml by 12%, and fall in tachycardia. Now, this may be confabulated if somebody is on, this may be not happening to the extent that you would want them to happen. And then you can look at by passive leg raising test. Now, you need to be aware that there is false positivity and false negativity with this one. But I wouldn't get into much. The most important is that the patient is spontaneously breathing. You cannot do certain tests. Next slide, please.
Yadullah, I hate to disturb you, but I think we are over an hour and 6 minutes.
Yeah, so, 5 minutes. Next slide, please. So the resuscitation early goal-directed therapy came from reverse trial, where they tried to maintain the CVP normal and MAP greater than 65 and SCVO2 greater than 70. And they showed that there was an improvement in mortality. There was a huge mortality benefit in the patients who had early goal-directed therapy versus non-goal-directed therapy. Next slide, please. And then next slide. They did subsequent lots of trials like Process, Promise, and Arise, and they couldn't actually reproduce these results. The simple reason why they couldn't reproduce this result was in reverse trial, they did this trial, and at that time, the control group didn't focus on fluid resuscitation in a goal-directed manner. The practice changed so immensely after that you cannot reproduce the control group of reverse trial. So that's why you didn't see any benefits with these ones. Next slide, please. Next slide, please. So optimization phase, what are the parameters that you're going to look at? Keep MAP greater than 65, cardiac index greater than 2.5, pulse pressure variation less than 14, intra-abdominal pressure less than 15, and abdominal perfusion pressure greater than 55, and aim for a ZBI of 640 to 800 ml. Next, please. Next slide, please. So as we have talked about, a fluid overload and positive fluid balance leads to organ dysfunction in almost all important organs, makes ARDS worse, make heart failures worse, makes causes gut edema, prevents absorption of essential nutrients, and impairs healing in gut surgeries, causes hepatic congestion, and can make patients encephalopathic. Next slide, please. In the stabilization phase, apart from the previous parameters that we have told, the aim would be here to make sure you're not over-resuscitating the patient. So extravascular lung water volume index needs to be kept at 10 to 12. That's normal, and pulmonary vascular permeability index less than 2.5. So what they were trying to say is that keep it neutral, and what guides us is looking at the vascular lung water index, that you can have these indices on having PICO or at the bedside by doing an ultrasound. You can indirectly assess whether somebody's having pulmonary edema. The other way is to look clinically, listen clinically, which is not that sensitive, and looking at the chest X-ray. Next slide, please. In the evacuation phase, you try to sort of prevent a hit by causing volume depletion. Next slide, please. So conservative fluid resuscitation and de-escalation has been shown to be beneficial in multiple randomized controlled trials. Next slide, please, and meta-analysis. Next slide, please. So the role of albumin, giving 20% albumin, there's a good deal of evidence in patients with hepatorenal failure, and stage 3, level 3 evidence in patients with sepsis. Next slide, please. Next slide, please. So if you're not able to remove in the later phase fluids, sometimes you would have to resort to renal replacement therapy in order to remove the fluids and in order to prevent the patient from getting fluid overloaded and improving the organ function and facilitating organ recovery. Next slide, please. Next slide, please. Next, please. So therefore, these are the take-home messages. When to start giving fluids: when patients have got low global end diastolic volume index or high pulse pressure variation, or a positive passive leg raise, or a high lactate. Aim would be to get the lactate less than 2. Next slide, please. When to stop giving fluid: when you have got a high global end diastolic volume index or ejection fraction, or low pulse pressure variation, or negative passive leg raising test and normal lactate. Next slide, please. When to start removing fluid: if somebody has got high extravascular lung water index or high pulmonary vascular permeability index, or raised intra-abdominal pressure, or decreased abdominal perfusion pressure, which is nothing but MAP minus intra-abdominal pressure, or CVP, and somebody who has got a positive clinic fluid balance. Next slide, please. When to stop removing fluids: this is this experimental thing. First line is low ICG PDR, that's idiocyanin green plasma disappearance rate, or low abdominal perfusion pressure, low SCVO2, and neutral cumulative fluid balance. Next slide, please. As we have already discussed this. Next, please. Now, maintaining euvolemic status and preventing, avoid giving contrast. That's the best advice. But if you are to give a contrast, make sure the patient is euvolemic. Now, there is whether you give it resuscitate or make euvolemic the saline or bicarb, there's not much huge difference. I normally give 3 cc of 3 ml per kg of bicarb, 1 hour pre and during, and 6 hours post procedure, 1 ml per kg per hour, if the patient is not alcoholic. Next slide, please. One size doesn't fit all, so you have to individualize the treatment and care. Next slide, please. Questions, time for questions. Thank you.
Thank you so much, Yadullah. So much information you've given. You packed literally several books of physiology and pathology and pharmacology and clinical medicine in 1 hour and 10 minutes. Enormous. You're always full of knowledge. We should have split into 2 lectures. Actually, what we'll do is that we'll post all these recordings onto our webpage and ask students and lecturers and teachers and participants to pose questions directly to you, because we have run out of time and we have one more lecture that's starting soon after. I think we'll probably overrun by 10 minutes. My only question would be that what is the basic cause of acute trauma, acute kidney injury? I mean, as a layperson, non-medical in the sense, if somebody wants to ask, what is the commonest cause? By the way, I like your new look.
So the commonest cause of acute kidney injury by far is sepsis.
Sepsis.
Yeah.
Caused by anything. Sepsis by anything, like
Sepsis
simple
can be
infection.
caused by bacterial infections, viral infections, fungal infections, and it used to be bacterial infections, but COVID changed the paradigm. As you can see, a lot of people with COVID ended up having AKI, and the incidence of AKI was very high, and people who had AKI with COVID and other organ involvement had higher mortality.
Do you still see COVID in where you are at the moment? You see patients
No,
of
the
COVID?
incidence of COVID has dramatically gone down, and the COVID which we are seeing now is not the same as we saw at the beginning of the pandemic. And the beginning of the pandemic, it was pretty virulent with multi-organ involvement at its worst, and people ended up being on ventilator and multi-organ support. The patients which we are getting, almost a majority of the population is vaccinated, and even if they are having COVID, they are not having that much in terms of organ involvement, including respiratory support or renal involvement.
Now, you have experience of working in both climates, like Asian population as well as the European populations. Do you find, or did you find any difference between the 2 cohorts, like the European population and the Asian population, like India, Pakistan, Arab population?
So I think in terms of outcomes, obviously at the worst end of the spectrum, the patients were non-salvageable. And at the best end of the spectrum, people got infected and didn't even know they were infected. But in the middle, who could have been saved by appropriate measures in terms of supporting the organs, treating infections, whether it's a super bacterial or fungal infections, and providing organ support. It actually boiled down to what facilities that the healthcare system had to provide. So at one paradigm in Asian population, you had a disastrous outcome where people were dying without oxygen. And at other paradigm, you had, like in Saudi Arabia, we have got about 125 beds, ICU beds, 10 ICUs in us. And we opened up 4 ICUs. We were never short of ICUs, ventilators, or dialysis machine. So people who were 80s, who were 90s survived that with organ failures. So the outcomes were good. And people who were very fatal, who sort of had a cytokine sort of syndrome, and then they wouldn't have survived it despite organ support died. But even in the Western subsector, we have got in certain European countries and even in UK, we found that at the peak of pandemics, when we are not well prepared and we had a surge, people died because of lack of adequate resources.
Thank you.